Okay, great, excellent. So we'll talk today about hemangioblastomas, the relative experience that we had at MGH about the treatment of this disease, and how belzutifan came to change the essentially natural history of the disease and provide to the patient some new exciting perspectives. It's a clinical talk, despite the fact that I'm the basic science component of it, with a little bit of flavor of some of the research directions that we're going lately. So as you all know, life for the VHL patients changed in August 13 of 2021 when FDA approved belzutifan for kidney cancer, for neuroendocrine tumors of the pancreas and hemangioblastomas of the central nervous system, all as part of the VHL disease. So let's talk a little bit about the VHL disease. Everybody's familiar with it, and Dr. Linehan went through it, so I don't want to duplicate this effort. But initially we were under the impression that the major morbidity in the VHL patients was coming from the renal cell carcinoma. We grew to realize that hemangioblastomas are more prevalent than renal cell carcinomas. And as a matter of fact, they are responsible for major morbidity in the disease. Due to the pioneering studies conducted by the NIH and Marston and Ram, we knew how to treat effectively and protect the kidney function of the VHL patients even before belzutifan. But hemangioblastomas are tumors that they require craniotomies. They cannot transplant. They cannot transplant brains and can transplant kidneys, and therefore they leave patients with major deficiencies, even if the tumor is removed. They are distributed as well, as you all know, in the cerebellum. They're distributed in the spine, in the retina, which is an extension of the CNS hemangioblastoma. And it's an interesting clusters of them in the hypophyseal area and the hypothalamic area. You see it here indicated. Here is my arrow, if you can see it indicated with this red spot. And I believe that these are actually behave differently in biology than the rest of the hemangioblastomas. The typical VHL patient is a young person. The onset of hemangioblastoma starts at age 9, and there are multiple of them, as we said before. Extremely rarely we see hemangioblastomas in locations that they're not usual, like the skin, the liver. Have seen a hemangioblastoma actually in the osseous component of the pelvis. In contrast to the VHL patients, people with sporadic hemangioblastomas are more aged. They have usually a single hemangioblastoma, and they don't have a family or personal history of the other tumors that are associated with the VHL disease. Having said that, there is an important detail for everybody who takes care of patients with hemangioblastomas. And this important detail is that reflected here in the paper that Dr. Maher's group in UK put forward. They took 180 consecutive patients that they have seemingly sporadic hemangioblastomas, meaning they don't have another VHL tumor and they do not have a personal or family history of another VHL tumor. Out of these seemingly clinically sporadic hemangioblastomas, 5% of the patients did have a germline VHL mutation. So 5% of them classified clearly as VHL patients. 10% of the ones that did not have the VHL mutation, they developed some type of VHL tumor within the next 10 years, that being renal cell carcinoma or paragangliomas or neuroendocrine tumors of the pancreas, which tells me, and I think to the authors, that there is about 15% of the patients that they appear to have sporadic hemangioblastomas, they may be VHL or have a mosaic disease. We see a lot of these patients in the center here at the MGH, and we also see some different versions than the typical ones of hemangioblastoma. These are the hemangioblastoma. This is a rare but very aggressive disease of spreading of the cells of the hemangioblastoma in the leptomeninges. It's almost like carcinomatous meningitis, and despite attempts of treatment with radiation, sunitinib or pazopanib, it is a lethal disease. Now, if we take the typical forms of the hemangioblastomas, we know that these are grown in an unpredictable form and in a very variable form. They can stay hibernated for a long period of time, indicating here by this flat line. They can grow very slowly with a different growth rate slopes, or they alternate between periods of dormancy and periods of incremental growth. Unfortunately, we don't have a single biomarker that can predict the expansion of a hemangioblastoma other than the development of edema, swelling around the tumor in MRI or CAT scan imaging, which is probably a late phase biomarker. How do we treat this disease? There's a lot of people that they would relate on treating the disease with radio surgery and radiation therapy early on the disease. The field is full of conflicting data and disagreement among the experts. They're not very sensitive to radiation. We do know that they respond, particularly if they're less than 1 centimeter the tumors and they don't have a cystic component. Unfortunately, they get worse before they get better, meaning that they increase in size because of the inflammation. So minimally symptomatic hemangioblastomas is a contraindication to treat with radiation therapy. And in the end of the day, after couple of months or years, they haven't responded significantly my shrinkage when we apply the RECIST criteria, but they mostly went into a kind of a sleeping hibernation mode. Eric, Jonas, and colleagues from MD Anderson tried to treat these patients with sunitinib, and in contrast to the response to sunitinib that we see in renal cell carcinomas in VHL patients, there was absolutely no response in hemangioblastomas. And now add to all these prior to the belzutifan problem, the fact that they're hemangioblastomas, that they're extremely difficult to treat with surgery, and our neurosurgeons and other neurosurgeons would avoid approaching them. These are the anterior ventral hemangioblastomas, supratentorial hemangioblastomas in the hypothalamus, you can treat them. Brainstem hemangioblastomas, they're not amenable to surgery. The cerebropontine ankles, they can be operated, but we're a little bit leery about the long-term effects. And the hemangioblastomas in the optic nerve could not be radiated with laser, and therefore that was a kind of a uniform lesion that led to blindness. So we're all familiar with belzutifan, taken 120 milligrams daily. This was the data that was briefly presented from the phase 2 study so that I can go then discuss in particular the hemangioblastomas. Belzutifan disrupts the complex, the dimeric complex, heterodimeric, that HIF2 alpha has to enter in order to bind DNA and transactivate genes, and therefore switches off the HIF2 alpha target genes. Now, I don't need to remind to this audience, the experts actually that they have done this work are here. We all know that there are 2 flavors of the HIF alpha, HIF1 alpha, and HIF2 alpha. HIF2 alpha has been proven to be, in my opinion, an oncogene in renal cell carcinoma, glioblastoma, and non-small cell lung cancers in engineering mouse models and in tissue culture. HIF1 alpha actually has properties of tumor suppressor gene in this corresponding disease. In all fairness and scientific stringency, we do not know yet the different roles that these 2 paralogs play in the case of hemangioblastoma. Given the clinical responses to the belzutifan, we suspect that hemangioblastoma, that HIF2 alpha is operating in hemangioblastoma, but whether or not HIF1 alpha is a tumor suppressor gene, is a redundant gene, or whatever other function it has, it is not known. So the study that led to the approval of the belzutifan is based on 61 patients that they were all entering the study based on having renal cell carcinoma. In several places like Mass General Hospital, we also added patients that they have hemangioblastomas in order to see the response. Today, 23 studies, 23 patients up to date have discontinued from the studies. 6 because they had a progressive disease that was associated with renal cell carcinoma, and others with various reasons that they're not particularly associated, related to side effects or adverse effects of the medication. This is a very well tolerated medication. This graph shows essentially in one peak the dramatic effect of the medication in renal cell carcinoma. On the left, or the red arrow, is the growth rate of individual renal cell carcinoma lesions in these patients over several years. And on the right side, you can see the growth after the application of the drug. So a positive growth of 3.6 millimeters per year was followed by a negative growth, a decline of 4.4 millimeters per year. The onset of action of this medication in the renal cell carcinoma can be delayed. It takes approximately 6 months, or it can take up to 6 months to start see action. And we have seen very delayed complete responses. Here is the map of the different procedures in nephrectomies, craniotomies, pancreatic surgeries, retinal interventions prior to the application of the belzutifan, and all these dots tell you how many procedures the patients go on, and after the 0 is the application after the rate of the procedures after belzutifan. And you can, it's very clear that there is a dramatic reduction for the requirements of these procedures. As I said before, it's a very well tolerated medication. Anemia develops invariably, almost in 90% plus in these patients, and they can be tolerated at different degrees. Very rarely we had to reduce the dose or to intervene with this anemia. I support this anemia by injection of erythropoietin personally. And very interesting side effect is the development of shortness of breath in some of these patients. And I think that there are some categories of patients that their regular breathing is actually depending on HIF-2 alpha, and therefore the medication decreases their oxygen. It's a point that needs to be paid attention. We don't give this medication during pregnancy. It's not compatible with pregnancy. And a clinical warning about this medication is that it weakens the levels of hormonal contraception, and therefore the pill is not an appropriate way of contraception. You need an IUD or mechanical contraception, but any case non-hormonal one. And the last point of maybe an exacerbated worry about it is that we don't know what's the effect of male fertility and female fertility, and therefore I consult my patients to bank oocytes and sperm if they are having a future interest in children, for women that they bear children, male that they want to procreate. So how about the hemangioblastomas? Because there was a long-winded way to arrive here. There has been a response. 50 patients of the 61 have hemangioblastomas, and the overall response was approximated at 44%. The median duration of response was not reached, and there was not essentially almost progression of disease in the case of hemangioblastomas. We had 4 complete responses in this hemangioblastomas, 4% of complete responses in hemangioblastomas. There are several methodological, and I'm sure that a lot of you have seen variable numbers of percentage of responses, and this is due to the fact that there have been several methodological problems in analyzing responses of the hemangioblastomas I'm going to touch in a second. Here are some examples. This is a baseline imaging of the hemangioblastoma in the left cerebellum, and 6 months later, week 24, there is a significant response. This is hemangioblastomas in the baseline in the cervical area, and at week 24, we have significant responses. The response to the hemangioblastoma to the belzutifan, we followed very closely here at the MGH, and I can tell you that the response is much more rapid than the response that we see in renal cell carcinomas. We do see responses within 6 weeks, and whether or not the response within 6 weeks is a good indicator for a long-term PR or an even CR is not known right now, but we're analyzing the data with this question in mind. This is another patient of mine that had hemangioblastoma in the area that's called Zenu, indicated here by the red arrow. It's not an area that you can radiate or an area that you can operate, and this is the cystic component of the hemangioblastoma in the lower part of the figure. 3 months of treatment, not 6, 3 months of treatment with hemangioblastoma, 12 weeks. We had almost a CR. This is a very good PR. The solid mass has disappeared and the cyst had decreased. Both cystic and solid components almost proportionally decrease in hemangioblastomas, and I said before, they do that in a very early, immediate, quick fashion. We see that within 6 weeks. Here is a patient that was on her way to the OR with a baseline 37 millimeter, 3.7 centimeters tumor, and severely symptomatic despite being treated with steroids and pazopanib. We tried, maybe a little bit too risky or cavalierly, to treat her with belzutifan, and at a month and a half, in 6 weeks, her tumor decreased from 3.6 to 0.6. At 12 weeks, which is the 3 months, her tumor was down to 24 millimeters. That's a impressive PR, and I can tell you that this patient continues to respond. She's totally asymptomatic, went back to work, and off any other type of medication. What have been the methodological problems in evaluating the responses in these clinical trials? And I would actually ask any of the colleagues that they're here now and they're interested in clinical trials to contact us in the MGH to organize the next clinical trial in hemangioblastomas. The problems here is that officially the RECIST criteria exclude the target lesions that are less than 1 centimeter, but we do know that depending on the location and the cystic areas around them, this can contribute to the mortality, to the morbidity of the disease. Not all target lesions were included. There was no difference between growing and not growing target lesions. And the evaluation was based exclusively on the solid component and not the solid and the cystic component, which is the total volume of the tumor. As we all appreciate, these tumors are not infiltrating like the glioblastomas, but they cause symptoms because of space-occupying nature in a closed cavity, which is our brain, and therefore the total volume is important. And as I said, there was no distinction between growing and stable hemangioblastomas. We have now about 20 patients, and 16 patients actually, that they are in the treatment with belzutifan off trial, and 10 patients that we have from the trial, and we put all this data together. What I can tell you so far is that in these patients, we did not have a complete response. We do not have any progressive disease, and approximately 50% of the patients have a very good, very solid partial response in hemangioblastomas. There are many future clinical questions that they relate to this medication. to the hemangioblastomas specifically, but also to the renal cell carcinomas. Should we treat young patients with a single lesions instead of operating? For how long should we treat the patients? Should we treat them continuously or intermittently? Does RCC or hemangioblastoma flares up after discontinuation of the belzutifan? And despite the fact that we have not seen resistance to belzutifan in hemangioblastoma yet, I mean by progression of the disease, we did see progressive disease, de novo resistance in renal cell carcinoma, and we analyzed the molecular fabric of this. 3 words, 3 slides, and I'm going to stop because I took more than the allowed time about the research activity, some of the research activities in hemangioblastoma. We did a genomic analysis of approximately 17 tumors, and we'll continue the genomic analysis of sporadic and VHL-associated ones. All of the tumors have biallelic inactivation of the VHL disease. In contrast to the renal cell carcinomas, we do not see mutations in other driver oncogenes or tumor suppressor genes in hemangioblastomas. So this has a very quiet genomic background, which probably is compatible with the non-infiltrated nature of the tumor. We do see copy number aberrations, though, and now we're focusing on the genes that they're involved in these areas that they have been deleted and activated. And after extensive single cell analysis, we think that we now can actually zoom and know what are the cells of origin of the hemangioblastoma, because these are the tumor cells that they have mutations and copy number aberrations. So I'll stop here and I'll take any questions. Thank you for listening to me.
Thank you, Othon. That was very encouraging stuff and very informative. Questions from the audience first. Okay, we have several questions here. I will ask one of the tech support if they could just read these questions for me. That'll be great because they're fairly lengthy. Could we do that?
I can. Do you want me, Mike? Do you want me to read them?
Yes, go ahead.
Okay, I'll start from the oldest to the newest. I think these are patients-related questions. I have been taking Welireg for 11 months. The last few weeks, I have developed a few small growths in my mouth and my bottom lip. Have there any reports of mouth source growth from this medicine? The Welireg has reduced the size of my multiple tumors, and I'm thrilled. Thanks. I'm not aware of mouth sores related to actually to Welireg as a specific adverse effect. Now, there is one rule that applies of using any medication, and the rule is anything can be done by any medication. So if these are mouth sores that they cannot be treated with some of the specific solutions that your doctor can give you, then I would say that it is worth reducing the dose. Or if you can tolerate it, I will keep the dose as it is. But no, I don't know anything specific about this. Second question. It's from a colleague from Milan. What is your comment on preclinical data stemming from analysis of surgical specimens after removal with the same approach presented earlier by Dr. Rowe? Yes, so that's exactly what I was alluding the last slide. We have done single cell analysis of these tumors. We have seen inflammatory components, we have seen immune components, and we have seen a mixture of cells, some of which do have copy number variations or the secondary somatic mutations, and therefore we think that these are the tumor cells. I think I should be able and ready to present this data very soon. Is there any data about response to belzutifan in the subpopulation of hemangioblastoma patients with cystic lesions? Yes, Welireg reduces both the solid component and the cystic component of the hemangioblastomas almost proportionally. So cystic component, in contrast, for example, to the radiation therapy, which can stop the solid component but not affect the cystic component, Welireg is active in both of them, and this is the beauty of the medication. Also, there is a quick alleviation of the edema that is around the tumor. So as you're very well aware, as patients and colleagues, many of these symptoms are not due to the actual size of the tumor, but a lot of the edema that is around the tumor. So the edema is actually reduced within 2 to 3 days, and we have seen dramatic improvement in symptomatology without improvement of the tumor itself objectively, even within 2 or 3 days. I'm going to the next questions. I have 2 questions. One, do you see, do you see
the last 2 questions?
Yes.
Okay.
Do you see the same good response also in retinal hemangioblastomas? The answer is yes. Ophthalmologists have been very much impressed by the response in the retinal hemangioblastomas. The second component of this question is, since anti-angiogenic therapy resulted most ineffective so far, what do you think is the effect of belzutifan at the tissue level? I'm not sure I understand these questions, but let me compare a receptor tyrosine kinase inhibitor to belzutifan. A classic, if we mean anti-angiogenic therapy, the receptor tyrosine kinase inhibitor or the VEGF inhibitor, or the bevacizumab anti-VEGF antibody, these are taking out one single component of a multi-angiogenic response that's orchestrated by HIF. These are 1 or 2 downstream targets of HIF. In contrast, belzutifan is attacking HIF itself, so it's attacking essentially the nodal component, the root of the problem, the hemangioblastomas, and I think this is the reason of the dramatic difference in the response. And Anna Matinia says, what are the cell types in your hemangioblastoma tumors? I mentioned before, these are pleiotropic. There's almost like every cell type that you can find in the central nervous system. And the analysis that we do, as Anna does in her lab, is to try to find out what the negative cells are as a single or multiple cell populations. I'll talk to you more about this, Anna.
Thank you, Othon. That was terrific. So that